By way of introduction, I'm Mindy Gentry. I'm a cardiologist that works for WellStar Medical Group, which, for those of you who aren't from the Atlanta area, WellStar is a health system that has hospitals and offices mainly north of the perimeter, so just north of the city. I did my undergraduate training at Georgia Tech, so here in Atlanta, and then my medical school training in Augusta at the Medical College of Georgia, where I was for 14 years, did all my training there. And then I've been on faculty here at WellStar for about the last 3.5 years, and I run the women's cardiac program for WellStar. And so thanks to CardioDx for inviting me here today to talk a little bit about women and heart disease, something that I love to get in front of an audience and talk about. I kind of feel like I'm preaching to the choir here today, though. I feel like most of the things that I'm going to address, which are primarily just some general statistics and knowledge about women and heart disease, all of you, many of you probably already know. And then after I finish, Jan McAllister will come up a bit and talk about a new test, a relatively new test that's available called Chorus CAD. So again, as most of you are probably aware, the leading cause of death in American women is cardiovascular disease. And as evidenced by this graph, cardiovascular disease kills just under 500,000 women per year. It kills more than the next 7 causes of death combined. More than twice as many women die of cardiovascular disease in this country than die of all forms of cancer combined. And more than 10 times as many women die from cardiovascular disease as die from breast cancer. And study after study would show that we as women and as healthcare providers tend to overestimate our risk of ourselves or our patients developing and dying from breast cancer and significantly underestimate the risk of cardiovascular disease. This graph shows the cardiovascular mortality trends since 1979, and you'll notice that right here in 1984, these two lines crossed. The red line is for women, the blue is for men, and every year since 1984, more women than men have died in this country from cardiovascular disease. And this is specific to acute MI. So this is a mortality graph, again, the women in red and the men in blue, that show the death during the index hospitalization after a myocardial infarction by age. Now, as you might expect, younger people tend to die less frequently after a myocardial infarction than do people as they get older. But interestingly, if you look at this, the death rate for women, and in particular young women, is significantly higher. In fact, in some cases, almost twice as high as their age-matched counterparts. Now, there are probably a lot of reasons for this. Most of these stats have probably multifactorial reasons. But one of the reasons is probably evidenced by this. This is a graph that shows the proportion. It's a little busy, so I'll explain it. But this color blue, the first blue here, are the proportion of all patients with a myocardial infarction in the U.S., the percentage that are women. And this goes back to the 60s and then comes up to 2000. So the percentage of acute MI patients that are women has increased slightly over that time period. And then if you look at the proportion, and this is all MI trials, and these are U.S. trials, but if you look at the proportion of patients in these trials that are women, there's a big discrepancy between the percentage of our patients that are having myocardial infarction and the percentage that are enrolled in the myocardial infarction trials. Now, this becomes an issue when we use the data from these MI trials to treat our female and our male patients. We kind of take the results and apply them to everyone. But in many cases, the results may not necessarily be applicable or appropriate for our female patients. Unfortunately, a lot of the studies prior to the early 2000s really didn't even report their data, gender-specific data. So we can't even go back and look at that data to see if these things made a difference, whether you were female or male, if there was a difference in response. But we know, for instance, from the Nurses' Health Study, which was a study that looked at the use of aspirin for primary prevention of coronary disease, and took essentially healthy women with no diabetes and no coronary artery disease, randomized them either to aspirin daily as a preventative mechanism for coronary disease or placebo, and found that there was absolutely no difference in the risk of development of coronary disease for women taking aspirin. So women, particularly women under the age of 65, derived no benefit from aspirin, as opposed to men. The exact same study was done about 10 to 15 years earlier in men, the Physicians' Health Study, which showed a 40% reduction in the risk of MI. So even something as simple as aspirin, or seemingly simple as aspirin, very different responses in women and men. And the Nurses' Health Study I just mentioned, of course, I said it, but I'll repeat it, is for primary prevention. So we're not talking about women that have had an MI, that was not women that were diabetic, and it was not women, women that have had stents placed before. So that, but clearly there are differences in how women and men respond to therapy, respond to preventative mechanisms, and respond to treatment once the diagnosis is made. About every 3 or 4 years, there's a survey done that looks at the knowledge, various things, but one of the things they look at is the knowledge of the risk of heart disease in women. And they survey physicians, 500 physicians usually, 300 primary care, 100 OB/GYN, and 100 cardiologists. And they do a whole variety of questions and clinical scenarios. But one of the questions that they usually ask is just true or false. Very simple question, true or false, more women than men die of heart disease every year in this country. And if you remember back a few slides ago, we saw that that's been true every year since 1984, so it's not a trick question, it's not a new phenomenon. But what percentage, somebody just take a guess, what percentage do you think of physicians, this data is from 2006, so in 2006, knew that more women than men die of heart disease? 40, I heard 40 over here. Anybody else got another guess? 25, 15. So we're getting closer. These are optimists over here up in this corner. I like that. But unfortunately, it was 8% of primary care, 13% of OB/GYN, and only 17% of cardiologists, which hang our head in embarrassment. I mean, that's terrible. So clearly we have a lot of work to do, not only in educating our patients that they're at risk for heart disease, but in educating ourselves in the medical field as practitioners. Changing gears just a bit, when we have patients come into the office, when you see patients with chest pain, the usual course of events is that you see the patient, you assess their clinical risk factors, how likely you think it is that based on their risk factors and their symptoms that they have obstructive disease. Typically, there's some sort of non-invasive imaging, including some sort of stress testing, and then may or may not also progress on to invasive angiography. The challenges that we have in women, and they're not exclusive to women, but they tend to be more commonly seen in women, are that women are more likely to have atypical symptoms, non-specific symptoms, or milder symptoms that may be a little harder to pin down and a little harder to identify specifically that they're coming from coronary disease. Women tend to have a higher false negative as well as false positive rate for all of our types of stress testing, and I'll go into more detail on this in just a minute. Lower rates of obstructive disease if they do make it to angiography. Increased side effects from radiation exposure, higher rates of contrast-induced nephropathy if they do have an angiography, increased risk of thyroid dysfunction from contrast agents, and definitely a higher risk for vascular complications and bleeding post-procedure. So clearly we want to have a way that we can accurately identify women that are at high risk for or are very likely to have obstructive coronary disease so that we can treat them appropriately, but we don't want to cast the net so wide that we send too many women for potentially damaging or potentially problematic procedures such as angiography, unless we really have to. So, not looking at just women, but this is a study that was in the New England Journal that looked at 400,000 patients that were referred for elective cardiac or elective angiography, so cardiac catheterization. And only 38% of those had obstructive coronary disease. So low yield at angiography for all patients in general. In this particular instance, 62% undergoing cardiac cath did not have obstructive coronary disease. And of course, before people make it to cath, most of them have had some sort of non-invasive imaging, which has implied a positive stress test that would make you think that their likelihood should be higher than this. This is data from the PREDICT study, which is one performed by CardioDx that was a cath lab study. So these were all patients who had some sort of evaluation and had been deemed by their practitioner to need a cardiac catheterization. And what they found is that the percent of patients that had absolutely no coronary artery disease at all, fairly high in men, 18%, so close to 1 in 5 had no coronary disease, but in women that was over 1 in 3. It was 38% had absolutely no coronary disease. And fairly small percentage that had obstructive disease in women, especially only 22% of women in this study that were sent for catheterization actually had obstructive disease. So a whole huge pool of people that it would be nice, of course, every single patient you send is not going to have obstructive disease, but it would be really nice to have a way to reduce that 78% of women who did not have obstructive coronary disease and try to prevent sending them for potentially hazardous testing like catheterization. This is, I believe this study is from Sweden, but yeah, Swedish Registry of Diagnostic Cardiac Catheterization. So the percentage of patients with normal findings in this particular study was very high in men and women under the age of 59. So if you were under the age of 59 and a woman and you were sent for catheterization, 80%, 79% did not have obstructive coronary disease. As patients get older, that percentage decreases, but it's still pretty significant, and you can see even in the 70 to 79 group, age 70 to 79, 49% of women did not have obstructive disease. So there's symptoms, of course, of which we're all aware that can be classic for angina, classic for coronary disease, and those are present both in men and women. Pain, pressure, squeezing, stabbing, exertional chest discomfort. I won't go through and read every single one of them to you because I know you're aware of most of them, but these symptoms are present in men and women. Now, if you look at women that have obstructive disease, the most common complaint is still chest pain, but women are a lot more likely than men to have more atypical symptoms, milder symptoms, such as sudden onset of weakness, shortness of breath, maybe back discomfort, jaw discomfort, shoulder discomfort that does not involve the chest. That makes it a little more difficult to sort out. So if you just look at patients that come in to primary care that have chest pain, the vast majority of these patients do not end up, after the workup is all said and done, having obstructive disease, needing PCI, needing bypass surgery. The percentages in this particular study were that 36% were due to musculoskeletal, 19% GI disease, psychosocial 8%, pulmonary disease 5%, and nonspecific 16%. So most do not have a cardiac etiology. Only 10% were because of stable coronary disease. So there are different ways that we can stress people. We have our old standby, the regular stress EKG, which is certainly of use, and we get more information from that than just the EKG changes. But if you look at the sensitivity, specificity, and accuracy of EKG, which on this graph is in red, sensitivity is not bad, about 77% in this particular study. Specificity in women is not great for a regular EKG stress test. We all probably know that EKG stress tests are more likely to be a false positive, which decreases your specificity, particularly for women. And then the overall accuracy is around 64%. So, not horrible, but certainly we should be able to do better. So if you add echo imaging to that and do a stress echo, which is nice because there's no radiation exposure with stress echo, which, as I'll mention in a minute, is really becoming a big deal, not only in cardiovascular imaging, but in imaging in general. The overall cumulative radiation doses that we're exposing people to with these repeat nuclear stress tests and repeat CT scans. But stress echoes are nice for that reason, because there's no radiation exposure. And you do increase your specificity and your accuracy, but still only around in the 80%. And most studies that look at this get the same ballpark figures. This is data on nuclear stress testing. And there are different reasons for the reasons that that nuclear stress testing may not be quite as accurate in women. You certainly have breast attenuation as a big part of it. But the right, your left, the specificity for EKG and for nuclear is there for men and women. The men are in blue, the women are in red. The gist of that is that, as we all know, that nuclear stress test, as well as stress echo and stress EKG, are not as specific or as sensitive, as you can see in the other graph, for women as they are for men. So not a terrible test, but hopefully we can do better. And this is just an example of what we see with breast attenuation when we read the nuclear stress test. That anterior wall, which is the dark part up top, see most of it's yellow, the rest, that anterior wall can look down or dark, which could indicate ischemia, but is often due to breast attenuation. Tough to sort that out sometimes. So again, this is data from the PREDICT study. And interestingly, they found, and this is a real-world use study, which probably applies to what we do day to day more often than some of the more stringent criteria studies. But with PREDICT, they found that whether the nuclear was positive or negative didn't really change the likelihood that the patient had obstructive disease. So 78% of the women in this study that had a positive nuke had no obstructive disease, and 82% that had a negative nuke had no obstructive disease. 22% that had a positive nuke actually had disease, and 18% that had a negative nuke did. So the nuclear stress test in this particular study was not very helpful at identifying women that had obstructive disease. And I touched on this just a minute ago, but the radiation risks are significant. And I think in the past we've really not appreciated that and are just kind of starting to think about that as we order these tests. But from a cardiac standpoint, the main source of radiation overall for our patients are these nuclear stress tests. Angiography accounts for about 21%, and then other PET, that kind of thing, accounts for about 4%. But by far the majority of radiation exposure for our patients comes from nuclear stress testing. And unfortunately, many of these patients don't end up just having one study. They have multiple studies, and so they have multiple exposures to radiation. One single nuclear stress test is equivalent to 39 mammograms. So, and many people get even 2 in 1 year. In this particular, 28% had 2 nuclears in 1 year, 56 had 2 in 2 years. And you know, we still unfortunately see people come in who you may have moved from a different area, changing physicians, and they come in for they say, oh, I'm ready for my yearly nuclear. And they've just, I mean, you look back, they've been getting yearly nuclears, asymptomatic, but getting these yearly nuclear stress tests for years. And I just kind of cringe every time I see that and just hope they don't end up with leukemia or breast cancer or some effect from the radiation. So again, going up the first bit over here, you have a patient come in that has chest pain. You want to hopefully be able to appropriately stratify them, risk stratify them, and decide what the appropriate therapy is for that patient, but do so in a way that doesn't significantly increase their risk of complication from either radiation or from an invasive study like a cath. So going down our usual pathway, may get an exercise stress test, which is not that expensive, but again, as we saw, accuracy is not that great. Oftentimes those patients, if there's a questionable exercise stress test, will go on for a nuclear or a stress echo, adds more expense. If it's a nuclear, it adds radiation exposure, and then if that's positive or equivocal, they end up going on for an angiography. And based on the data we talked about a minute ago, 75% of those patients that have made it all the way down that pathway do not end up having obstructive disease. So it would be wonderful if there was a way that we could knock out some of those, that 75%, before they make it all the way down that pathway, expense, radiation exposure, knock out some of those before they end up there to prevent them from having to go through all of that. But do so with accuracy so that we don't miss disease that does need to be treated. And that's where this Chorus CAD test comes in and where I found it to be particularly useful. It's a blood test drawn the same day in the office, typically get the results within 72 hours. And The negative predictive value for this test is excellent. It's 96%. So it does exactly what I said a minute ago. It really allows me to take patients that have maybe intermediate risk, intermediate symptoms, and if you start with the chorus with a 96% negative predictive value, if the test is negative, it's very helpful in making that pool of patients that then progresses onto a nuclear or progresses onto a cath much smaller. Now, theoretically, there's not data to support this yet, but theoretically, if you do that and you have a smaller pool of patients that you're cathing, the percent of patients that actually have obstructive disease and that you can help with an angioplasty or a stent should be significantly higher. And so I'm hopeful that this is going to be used more commonly and allow us, again, to decrease that pool of patients that ends up all the way at the end of that pathway at cardiac cath, or really even progressing on to a nuclear stress test.